Good evening, everyone, and a warm welcome from IAP Allergy and Applied Immunology chapter and All India Ophthalmological Society for the third episode of Eye Allergy Webinar series. Myself, Dr. Neeraj Gupta, and with me, my colleague, Dr. Rajshekhar Paul, will be your host for the day. Dr. Rajshekhar, a trained cornea specialist from Shankar Netralaya, and he is currently working as consultant at Shankar Netralaya, Kolkata, at Cataract and Cornea Services. Welcome, Dr. Paul. Over last 2 days, we have discussed about immunopathophysiology, clinical presentation, diagnostic tests, pharmaco and immunotherapy of ocular allergies. Today, we will be discussing about spatial situations, prevention, and importance of collaborative care. Before we start our session, I would like to request my colleague, Dr. Paul, to introduce our esteemed guest for the day who will be helping us during the panel discussion.
Thank you, Dr. Neeraj sir, for this very kind introduction. I would first like to introduce Dr. Vanati ma'am. She is the present editor-in-chief of India Journal of nominated member of Action Council of Ophthalmology and the vice president of Delhi Ophthalmic Society. She's an expert corneal cataract and refractive surgeon and currently a senior faculty at AIMS. Thank you so much, ma'am, for joining us today. Next, I would like to welcome core of this webinar, Dr. Shweta Agrawal, ma'am. She's a senior ophthalmologist from Shankar Netralaya, Chennai. Our third panelist will be Dr. Rushili Varad, madam, a senior ophthalmologist with an extensive experience in ocular allergies from Pune. Thank you, ma'am. And last but not the least, I would like to invite Dr. Vinay Pillai, sir. He's a senior consultant and head for cornea and refractive surgery services at Giridhar Eye Institute, Kochi. His special interests are in dealing with ocular surface disorders, corneal stem cells, keratoprothesis, aesthetic corneal disorders, high-risk corneal transplants, and pediatric corneal disorders. Sir will be our fourth panelist and also our first speaker of the session. We welcome you, sir.
Dr. Vinay sir, please share your presentation and start.
Sorry, I couldn't hear what was
No problem.
said last
Yeah, so
few
please
minutes.
share your presentation and start.
Yeah. Hope that is visible now.
Yes, sir, it is clear. You can start now.
Yeah, thank you. Good evening, everyone. And at the outset, I'd like to thank both IAP's Allergy chapter and AOC for this invite, and especially to Dr. Shweta and Dr. Neeraj for doing something like this. 3 days on allergy, it's something unique, I would say. I'm sure, past 2 days exercise would have been really exhaustive for most of the people who have been going through this webinar series. So with today's session, hopefully we can we arrive at some kind of understanding on how to have a collaborative approach in this specific condition. So one of the most common organs to have allergy is eye. And over the years, we have seen an increased prevalence of allergy because of various reasons mentioned, like industrialization and also pollution, urbanization, climate change, and the so-called hygiene theory. And again, I'm sure, all these things have been discussed about the types of allergy, how to classify, and based on clinical signs and symptoms, you can have seasonal, perennial allergic, VKC, atopy, and then other forms of allergic disorders. But again, Leonardo and group have kind of reclassified allergy or proposed that, based on the basic physiologic mechanism involved, it might be you may classify it into allergy and non-allergic hypersensitivity and allergy based on IgE mediated and non-IgE mediated mechanisms. So all these we have dealt in detail in the last 2 days. And coming to epidemiology of ocular allergy per se, the data from India is very, very limited. But whatever is available in the world, it says that nearly 40% of the population may have ocular allergy, and VKZ is not that common in the Western world, while it is not that rare in our situation. Of the various studies available, the prevalence is supposed to range from 8 to 10%. And mind you, all these are from hospital-based study, not on, population-based study. So there will definitely be a bias involved, but then this is what we have at the moment and what we have to manage with. More common in males, and the most common age group is from early to middle childhood, that is from 3 to 11 years age group. And prevalence is significantly higher in rural communities, and also in higher socioeconomic strata. Seasonal variation is known, and it kind of starts during February and peaks in May. And of the ocular allergies, what we have seen is vernal keratoconjunctivitis to be the most common form. Though both different studies say the commonest form of VKC is palpable or mixed, but then generally from my personal experience, I feel what we see is like the mixed form rather than pure palpable form as the commonest one. Now, what is interesting here is that though we say allergy is seasonal or allergic conjunctivitis is seasonal, more than half of the presented cases in the study from Chandrasekhar et al. Was perennial or chronic form. And it is interesting to note that a study from Italy has shown that a certain group, up to 16% of the seasonal form, evolved over a period of time into perennial form. Now, these are things which we should keep in mind and make it think: are we doing what is correct at the moment? The risks for ocular allergy are supposed to be male sex, again early to middle childhood, higher socioeconomic strata, and a history of systemic allergy. Complications are quite not that rare especially in vernal keratoconjunctivitis, but in other forms of allergy it is not that common. Risks again are supposed to be a history of systemic allergy and increased duration of disease. Now, coming to the topic per se, severe and refractory. In many cases, these terms are kind of used interchangeably, but are they really this one and the same? Not really. Now, what we mean by severe disease, in the VKC literature, there is practically no consensus on, on the definition of severity or on grading the severity. Now, why should we think about, having a uniformed grading or, a kind of definition or to understand what is meant by severe disease? This is mainly to help us in, suggesting or coming out with a proper and standardized treatment recommendations. Various, different ways of grading and classification systems are available, but then all of them are, fall short of some or other factors. And the most latest one is from, Shweta's group. It's quite interesting in the sense that there are a lot of new factors which has been included in this form, and rightly so. So they've classified it into mild, moderate, severe, and very severe. Mild with mild seasonal symptoms, and as it becomes more, frequent, like what they say is more than 4 episodes per year, you go into moderate forms, and then once these kind of the allergic manifestation or the acute exacerbation comes with corneal involvement, then they go into the severe, and any evidence of complications probably we can call it that's very severe form. So this is one a good way of looking at how to classify or grade a vernal conjunctivitis. In this grading system, they have also proposed various forms of how to treat them and the role of allergy specialist in. But then, as I mentioned, the advantages are, of this system is it incorporates complications. I think severe and very severe will have corneal involvement and corneal complication. And it grades the severity of the disease, irrespective of whether the disease is active or inactive at the time of presentation. And on the aspect of treatment, they have included the role of immunomodulators and the involvement of allergists. But then, like in most other grading classifications, this involves objective science. A lot of subjective science and symptoms are involved. But then one major, point which is lacking in all these forms of classifications and grading is the quality of life. Okay, how does this affect the patient, or in fact, more than the child, it is the parent and the family which is, affected or involved. This to me is a major factor which we have to really look into and come out with ways of addressing this, or rather before addressing, assessing this, and then probably that needs to be incorporated into the so-called severity grading systems. Now, another question here is, when we say quiescent severe disease, does it warrant treatment? If it warrant treatment, when do we treat it? Again, as all of us know, it's just not the the science that matters here. It is the history that is very important here. So probably that is one aspect which we have to look into when we think about grading the severity of the disease. Now, the other aspect is the refractive disease. So what constitutes a refractive disease? Again, the paper from Dr. Shweta have given proposed a definition for refractive disease. Basically, it boils down to a condition where we have addressed the VKC with the maximum possible topical medication, and the disease is not showing any response or is dependent on steroids. Now, why we have or all of us give importance to steroid dependence or steroid use is because of the complications that are associated with long-term steroid use. So, but then before we brand a disease as refractory disease, we have to make sure that the diagnosis is accurate. It's VKC and not associated with other comorbid conditions, which is actually worsening the condition and which we have not addressed. And then that has the child or the patient received proper adequate therapy. So a stepwise approach in VKC is what is proposed. And, initial, as as has been discussed in previous days, avoidance, topical anti-allergics, then low dose pulse steroids for intermediate flare-ups. When it is not getting control, or then when multiple low dose steroids is required, you shift to immunomodulators, topical immunomodulators. And when there is further, no response or further recurrences or multiple episodes when the patient is on immunomodulators, you think of, going higher steroids and, type of a short course of pulsed oral steroids to control the disease. And now, once we reach that level, we know for sure that it is the topicals or it's not working. The steroids are the only one working, and we may need to do something else. And that is when, till now, most of us think about getting some other help and refer it to an allergist or a person who is able to manage such situation outside the purview of just topical medications. But is that the correct way to do it? Again, in the severe and very severe form, yes, as I mentioned before, we generally think about managing or sending these patients to someone else who can do it. And there is emerging evidence which says that systemic treatment with topical immunosuppressives like cyclosporin, tacrolimus, and other agents like biologicals has got quite significant role in these severe and probably recalcitrant cases. It has been shown that these agents actually help in reducing the number of acute episodes, also, which in turn help in reducing the amount and the duration of the steroid use. Also, it has shown that with adequate dosing and adequate duration, there is a reversal of tissue remodeling that has happened. These are all quite, advantages to the patient in, having a relatively normal life and preserving his vision. But then in early disease, is there a role for systemic treatment, or is there a role for in referring a patient with VKC to an allergist? That is a question which is still unanswered. So this is a flow chart from that article, basically which shows that when there is a severe disease or a refractive disease, you have to sign, or you have to get further evaluation for systemic medication. But then again, as we all know, the treatment starts with proper education of the parents. The problem with early referral to an allergist is acceptance by parents. So this is where, as ophthalmologists and, as the first point contact with people with early ocular allergy, we need to spend time with them, with the parents rather, explaining to them the possible complication, the need, and the possible outcomes. So when do we refer? In addition to that, severe or refractive condition, probably an early referral is indicated because there is evidence to say that there is an evolution over a period of time from the seasonal, allergy or ocular allergy to perennial form. And in these cases, if detected and found possible, probably an introduction of disease modifying treatments like allergen specific immunotherapy might alter the course of disease. So that is which means the early referral has to be or may be considered in these cases. The role of systemic therapy is still evolving, but then there is emerging evidence to say that it is quite useful and effective in vernal keratoconjunctivitis. And in short, as ophthalmologists, all of us should have a proper communication with allergists and on the on what is expected from them in terms of ocular allergy and what we want to be seen in these eyes. So we should have our communication channels open, and since the over the years and decades, the information explosion is so much being kind of confined to just ophthalmology and its periphery. All of us are kind of blinded on what is happening to the world outside. So yes, collaboration is essential and it is the way forward. With that, I would like to conclude and thank you for listening.
Excellent talk, sir. So I'll quickly move over to a quick panel discussion. This is for Vanati ma'am. Ma'am, in your experience, what role does systemic therapies play in your treatment algorithm?
Can you just repeat the question, please? I couldn't hear the middle of it. Hello? Yeah.
Hello? Yes, ma'am.
Yes. Yeah,
What
I
does
can hear
the
you now.
systemic therapies, like the biologics and the immunosuppressants, play in your treatment algorithm?
Okay. I think it is, we usually do reserve it for refractory disease here. And we also reserve it for those patients where they have a lot of systemic allergy associated, systemic allergy either in form of, they have respiratory allergies associated with them, and patients of atopy is there. And these are the, general group of patients in which they probably are going to need systemic therapies as well. So by and large, this tends to form lesser percentages of our practice when we look at these, and these generally are already on these patients generally do seek systemic interventions from their physicians or from their allergy experts here. And it's a co-management which we always do encounter when we are looking at them. Atopy is one which I generally tend to send them across to our physicians and allergy specialists. And by and large, I think I don't have exact percentages, but then this is how my practice usually works.
Okay. So, Neeraj sir, we should move on to our next talk, sir.
So I would first like to congratulate Dr. Vinay. I think it's an excellent talk, and he has been very clear since the beginning, and especially the classification, which also suggests that it is like the timing of referral should be early. It should not be late. I just want to, you can say, like use an example from my intensive care practice. So somewhere around 20 years back, 25 years back, we used to, or the intensivists used to put the children on ventilators late enough. That means that when the ventilator was considered to be something like a rescue, that nothing else is working, and now you put it on the ventilator, and the outcomes were not great. Same thing was for ECMO support. The ECMO was initiated at that time when everything else has been failed, and now gradually over past, you can say, like 3 decades, the intensivists have learned a lot, that there is a window of opportunity, and this window of opportunity is the right time. And right time means that when the organs are still in the recoverable phase, then at that particular time, if you provide the right support, and then the outcome started becoming better. Now today's mantra is that we are putting the children, sick children, early on ventilator before the organ failure happens. Simultaneously we are putting the children early on ECMO support, and we are able to wean them off so quickly that our results are excellent. They are nearly 95 to 98%. We have got such excellent results. Same thing holds true for allergy. For allergy, if we are able to, because allergy is a systemic disease, we always feel that if the person is not responding or going into the severe disease or refractory disease, then probably that is the time that we need to go to the allergy specialist. Even if at that particular time you have gone to the allergy specialist, but the disease has already entered in the severe phase, it has already entered in the refractory phase, the organ damage, the tissue remodeling has already happened. And at that particular time, even the allergist intervention cannot reverse the tissue remodeling back. So the time is not that. The time is that it has to be early. So early could be probably the stage 2 or probably the stage 1, where we need to catch hold the things early so that it should not worsen further. We need to provide some allergen avoidance measures and immunotherapy in the selected cases if required, so that the tissue damage can be prevented. So when we are talking about severe and refractory cases, they can be actually prevented if we take our colleagues' help early. So that is important. So I think very well delivered message by Dr. Vinay. Thank you so much for doing that. And now, with which I would like to invite Dr. Deepti Pujari. So Dr. Deepti Pujari is going to talk us about the atopic march or allergic march. Now, this is an important phenomena, and in this phenomena, she will actually explain us that it is not the only eye which we are looking at. It is something beyond eye which we should look at proactively. And Dr. Deepti Pujari is a senior pediatric allergist, head of the department at Dinanath Mangeshkar Hospital from Pune, and she is actually really an excellent speaker. And ma'am, the stage is for you. You can share your presentation.
Thank you so much for that kind introduction, Dr. Neeraj. I hope I do justice to the talk because as I was listening, forget early, late. We are now, I'm going to present something. Can we do much, much, much before? Okay, before things have started, and can we really do something to prevent the progression, prevent the disease? Can we do it, catch it really early? And is it just a single eye symptom, or it's just a group of disease, and we are seeing eye is just one of the organs? Is it something more that we are dealing with? So let's talk about atopic march. I really thank Dr. Neeraj Gupta and IIP Allergy team for giving me this opportunity. Dr. Pillai gave a wonderful talk on vernal keratoconjunctivitis and, early, late. Let's see, can we do something else for our children? So I hope my full screen is seen and I'm audible.
Yes, ma'am, you are good to go. Please start.
Sure. Thank you. So, what is atopic march? Why I was given this talk? So, atopic march or allergic march, it refers to the natural progression of allergic diseases, okay, that typically begin in very early childhood and can evolve over the time. It illustrates how different atopic conditions are interconnected and may develop sequentially in a predictable manner. We can predict, can we? Let's see. And are they really sequential? So the atopic march describes the progression of allergic disease where first the atopic dermatitis is first to come. It appears very early in infancy. Then comes our IG mediated food allergies. Okay. And mostly by the time they are settling down, our allergic asthma comes up. So it's again seen in around 2, 3, 4 years in children. And then our allergic rhinitis and conjunctivitis, mostly they come together little late. Now we are seeing it even early. So maybe I'll say at around 7, 8, 10 years, 11 years, early adolescents, teenagers, they develop allergic rhinitis and conjunctivitis. So can we do something for them? Can we forget early or late reference? Can we catch them really, really early? So let's see how we can think over and how to develop our thinking process. So this is the typical progression which it's available all in all the textbooks. And so as you see, by the time our atopic skin condition and food allergies have subsided, they have settled, our allergic asthma and allergic rhinitis and conjunctivitis, they develop and we see full-blown disease in our teenagers. Okay. And India is nowhere back. And so in allergic conjunctivitis, we have reached almost 25% pure allergic conjunctivitis. And in children, it is up to 10%, but by the time they grow into adults, it's full-blown disease. And almost 60 to 80% are associated with allergic rhinitis. So, what is this atopic march? What are the early members of atopic march? Okay, so we all know the filaggrin gene defect or the loss of functional mutations in SPINK5 gene. It causes skin barrier dysfunction leading to atopic dermatitis, which is considered the major organ, the skin breakage is considered the major factor for the allergens to enter the body and sensitize the individual. So can we do something here itself? So polymorphism, I hope my internet is fine. Polymorphism is the gene encoding thymic stromal lymphopoietin receptor influencing atopic dermatitis, food allergies, asthma, and allergic rhinoconjunctivitis. What about the late members of the atopic march? Polymorphism in the gene interleukin 33, mostly associated again with atopic dermatitis, asthma, and allergic rhinoconjunctivitis. So there are some early members and late members. So can something be done? So till now it was dual allergen exposure hypothesis. Now it is said it's triple. So there is airway which causes allergies. If allergens are entering from from our airways, that is our nose and our eyes as well, are they come in this category. The skin is the major sensitizer. But if the allergens are entering early via the GI system, the gastrointestinal tract, we tend to develop tolerance. So that's all, the concept of LEAP study, which said early introduction of peanuts will help in causing the tolerance rather than allergies. So when the allergens enter via the broken skin or via the disrupted epithelium of the airways, that leads to IgE production and allergies. Whereas the GI tract, it causes T-reg cell production, T regulatory cells, and causes tolerance. So then again, the same question, can something be done? So atopic dermatitis and atopic march, which is first? So mostly now we know that the skin barrier dysfunction is the first to develop. The allergens tend to penetrate from the defective skin barrier. Epicutaneous sensitization occurs the type 2 inflammation leading to Ig-mediated response that then spreads to all over the body, causing food allergies, allergic asthma, allergic rhinitis, allergic conjunctivitis, which is the typical atopic march. This is what I have predicted. So not all are allergens. There are some triggers. We'll talk about it later. So this skin barrier dysfunction leading to TSLP, interleukin 33, interleukin 25, causing severe atopic dermatitis, atopic asthma, rhinitis, and conjunctivitis is the typical atopic march. Now it is important to know that not every patient with atopic dermatitis develops asthma, and not every patient with asthma has preceding atopic dermatitis. There are various, there was a big study done, two birth cohorts found various patterns, and these are the 7 distinct atopic patterns that are seen across the globe. So 3% would have typical atopic march, but again, roughly 3% would have persistent eczema and wheeze only. 4.7% and 5.7% will have eczema with late onset rhinoconjunctivitis and wheeze with late onset rhinoconjunctivitis. So very important. Then only rhinoconjunctivitis is seen in 9.6%, and remaining 51%, they had, the study said they didn't have any atopic disease. So it is very important, not that every atopic dermatitis patient will end up into allergic rhinoconjunctivitis. No, there are various patterns that are seen. But the temporal pattern for the atopic march is mostly that in infancy, it is atopic dermatitis and food allergies. And as the child grows, it develops allergic asthma, rhinitis, and allergic conjunctivitis, depending upon the skin barrier damage, the microbiome alteration, interference with the genes, the epigenetics. Let's see. So what is this microbiome alteration? Skin microbiome dysbiosis seen in early life in atopic dermatitis is coming in a big way. It's all about now probiotics, good bacteria, how much to give, when to give, which bacteria. So does it really matter? So studies are coming up and saying, yes, that if skin microbiome is altered, these children tend to develop atopic progression and ultimately end up into allergic conjunctivitis. So colonization with commensal staphylococci at 2 months was related with lower risk of atopic dermatitis at 1 year. So commensal, that is friendly bacteria. And in it, this study also showed that infants with low diversity in the intestinal flora at 1 month of age developed allergic asthma at school age. Again, good intestinal flora was lacking in these children. The studies mentioned above strongly suggest that microbiome alteration may be involved in the atopic march. So again, can something be done to give a good, rich, natural microbiome to our kids so that we can stop their allergic progression? Epigenetics is coming in a big way. Epigenetic mechanisms can regulate gene expression and constitute the cause of disease. Several epigenome-wide studies have revealed that DNA methylation in blood to be related to food allergic asthma, and if it progresses, then to allergic rhinoconjunctivitis. And we now know there are so many genes that are responsible for various atopic diseases and allergic asthma and further allergic rhinoconjunctivitis. So there is a delicate balance between infection and allergies. We know it is a balance, and if one goes down, the other comes up. We have adopted Western lifestyles, so our infections have gone down and allergies have gone up. So what are the confounding factors in atopic march? Our diet, hygiene, infections, allergens, air pollutions, environmental factors coming in big way. Influence of pathologic and commensal microbial stimuli, as I said, childhood antibiotic exposure. So, earlier we used to live in farm, we had joint family, there were so many kids in our family, infections were rampant, infestations were rampant. Now we have all started using Dettol's and Lysol's, nuclear family, good hygiene, good antibiotics for the smallest possible infection. That has led to what? All our infections have come down, and the second arm of the taraju has gone up, so our balance has shifted now, and so we are seeing so many allergies. And if environment factors, there is so much of pollution going on, these are all the triggers that play a major role in triggering our allergies. These are not allergens per se, but yes, they trigger our allergies. And what are the protective factors against the atopic march? Childhood exposure, as I was saying, our old time lifestyle, childhood exposure to household pets, livestock, unpasteurized milk, endotoxins, microbial, all in a good way. Huh? They all in a friendly, commensal way, not in infective way. So this all was has shown to decrease the atopic march. It is shown to halt the atopic march. And we all know, we have been seeing it over the last 2 days, people are talking about allergens. Dr. Neeraj talked about allergic tests. We know these are our outdoor pollens, these are our indoor allergens. Our house dust mites, our molds come in a major way causing allergic conjunctivitis. So yes, management involves a whole, it is not just one thing at one particular time, steroids given for 7 days, 10 days. It is a whole, it's like right from very early in life till the adult, that if there is atopy in the family, we have to treat the child as a whole, right from avoidance. Avoidance is so important in allergic conjunctivitis. So if the child is found to be allergic to house dust mite, we have to make sure we declutter our house and everything is swept, mopped, and our upholstery is to the minimum. We use good HEPA filters, so on and so forth. And if the child is found to be allergic to pets, if there are molds, all these need to come down. So our, at least the indoor and outdoor allergen should be allergen friendly. That's what I can say. If a child is found to be severely pollen allergic, we give them good glasses to wear. We ask the parents not to put the clothes outside if the pollen count is high. If the pollen count is high, we tell them to shut the windows and doors, so on and so forth. So definitely avoidance measures do play. But then comes the golden question, can we prevent the atopic march? It has to be started very early in life. There is something called primary, secondary, and tertiary treatment in all the allergies. Tertiary is something very late. We are thinking, can we do something much earlier? So, yes, primary prevention, a good healthy diet, our old time diet, good fresh vegetables, fruits, probiotics, fibers, uh, all good sunlight in mother itself is shown to decrease asthma, dermatitis, food allergy, allergic rhinal conjunctivitis in the newborn child and when the child grows big. The studies have proven this beyond doubt. What about secondary prevention? Again, microbiome is coming in a big way. So good vaginal delivery, which exposes the child to vaginal flora of the mother, giving maternal microbiota to the newborn baby. Kangaroo care, skin to skin, maternal microbiota again plays a good role. Exclusively breastfeeding till 6 months of age, a single most factor in preventing future allergies. Again, human milk is rich in microbiota. These simple measures have shown that we can decrease the atopic march. Sometimes we can even halt the atopic march. We can decrease the severity of the atopic diseases if taken in good time. Can skincare prevent atopic march? By focusing on repairing the skin barrier and adjusting skin's microbiome from birth, we might not only lower the chances of developing atopic dermatitis, but also change the course of the allergic march. Again, I have quoted in all the pages, I have quoted the studies from where I'm putting all this. The application of moisturizers may offer a protective mechanism against development of atopic dermatitis and restoring skin barrier, thereby preventing the entry of the allergens and thereby preventing further atopic march. So definitely there is an interplay between skin pH and microbiome. It is said that acidic pH needs to be maintained for good microbiome in the skin. So all the alkaline soaps and to the extent neutral pH soaps need to be prevented. A good maintaining pH around 5.5 of the skin is helpful in preventing atopic march. Allergen immunotherapy, we all know it works wonders. And again, this is a position paper which I am quoting. Everywhere it is said allergen immunotherapy should be considered in Ig-mediated allergic rhinitis and conjunctivitis when with appropriate pharmacotherapy and avoidance strategies. Still, there is allergic rhinoconjunctivitis. It is affecting day-to-day activity. It is affecting the sleep of the child. The studies allergen immunotherapy plays a big role, and now the uh, again the balance is shifting. We tend to start it very early. We don't wait for the disease to become severe. We don't wait for permanent changes to occur. We start early, and we can again halt the disease quite well. In less severe allergic rhinoconjunctivitis, to take advantage of long-term benefit on allergic rhinoconjunctivitis and potential prevention of asthma. This has come in a big way. And again, I have quoted the studies. So, to conclude, the global increase of atopic disease greatly lowers the quality of life. The theory of atopic march facilitates our understandings of the pathophysiology of atopic diseases and further promotes the early detection, prevention, and treatment of children at risk of allergic disease. With these underlying facts, allergic rhinoconjunctivitis can definitely be better managed with appropriate and timely interventions. There are further scopes. Further studies on atopic march would be directed at the following points. Firstly, the methods for data collection should be improved and disease heterogeneity or variations should be considered when performing substantial epidemiological surveys. Secondly, more detailed and logical mechanisms, including genetic and environmental aspects, should be explored to account for the temporal pattern, which would pave the way for novel approaches for the prevention and timely and early treatment of the clinical manifestations, ultimately reducing the allergic burden. Thank you.
So, Dr. Deepti, it was really a fantastic talk, great talk. So, I think there is a question. Let's take this question first and then we will go further. Dr. Shweta wants to ask about what do you mean by this 51% non-atopic and what is the difference between atopy and allergy? Excellent question. Dr. Deepti, please.
Now, in that cohort where the studies were done, in that study, 51 were found non-atopic. So allergy can be, you eat peanut and you may develop peanut allergy. That is your IgE manifestation. Atopy means that is going on, it is epigenetics is involved. It is your genetic potential towards allergy. And it has come over to you via birth. There is your potential is there to develop allergy. Can we do something to, prevent that march? That is your genes are there, your epigenetics is there, DNA methylation is already there in your body. This has happened over the generations. That is your atopic potential. And allergy is that when you manifest it in a particular way to a particular allergen, that is your pure allergy that you treat. But atopy can be prevented.
So I think excellently explained. So if I just want to rephrase it, so there are three terms. One is called as atopy, another is allergy, another is hypersensitivity. So let's understand what is atopy. Dr. Deepti beautifully explained that if there is a family history, if the first blood relative, first generation relative of that particular patient, they are affected, there is a history that father, mother, grandfather, whosoever, with the direct blood relation. So first degree relatives, basically, they are affected. Then at that particular time, this particular history says that, okay, this particular child is atopic. That means atopy is a genetic definition of allergy. If there is a familial tendency, if there is a genetic tendency that, okay, this particular child might develop allergies given the favorable environment, then at that particular time, this child will be labeled as atopic. Even if he is not having any clinical manifestation, he will be labeled as atopic. Hypersensitivity is something in which the test is positive, either the skin prick test or the specific IG, irrespective whether that particular test is matching with the clinical symptom or not matching with the clinical symptom. So hypersensitivity means it is the biochemical definition of allergy. So biochemical point of view, if the test is positive, it is hypersensitivity. On the other hand, allergy is a clinical definition. That means if there is a clinical history which is matching with the allergy, then at that time it becomes allergy. So sometimes it is possible that a person might be atopic but will not manifest allergic manifestation possible. There is another possibility that because of some de novo mutations or de novo changes or epigenetic changes, atopy history might not be there, but still the child might be allergic. So these terms are a little bit different. Atopy is basically genetic, hypersensitivity is something which is biochemical, and allergy is which is something clinical. Coming back to Dr. Deepti's talk, I think this was a different talk, and the purpose of talking this important atopic march or allergic march beautifully highlighted. What she wants to say is that it is not the eye which we need to look. It is the process. In the process of that, we are just looking at the cross section. If the child is presenting to us in the first cross section, probably he is presenting to dermatologist with eczema. Few years later, he will present to gastroenterologist with food allergy. Few years later, he will present to probably an ENT specialist or a pulmonologist with either asthma or rhinitis, and sometimes to ophthalmologist with conjunctivitis. And we all have a tendency to look it in the cross section. We do not try to make it as a complete picture, complete movie. If we just connect all these dots, then the complete movie will be explained. As she rightly mentioned, that there are pointers which can actually predict that, okay, this particular child is going to develop rhinitis, going to develop conjunctivitis at the stage when he is having only eczema, at the stage when he is having only food allergy. So the important point which has been beautifully highlighted, that we need to prevent, we need to pick up these children even before the onset of conjunctivitis, even before the onset of ocular allergy. That is our aim. And there are certain, you can say, like strategies by virtue of which you can actually do that, which I think Dr. Deepti has beautifully explained. Dr. Deepti, one question to you. Like, for an example, if you want to ask that who is going to probably go towards atopic march. So can you give us some pointers, especially when a 1-year-old child or a 2-year-old child or a 3-year-old child presents to you or to a pediatrician, and he can actually predict that, okay, 5 years down the line, 7 years down the line, he might develop rhinoconjunctivitis. So are there any pointers in the early life?
So mostly when you are asking me this question in this general forum, let's talk clinical. There's no point doing some tests. Let's see clinically if a patient child is coming to a clinic, can we predict, oh, this child is not going to do well? First and foremost, let's go back. Genetics. Again, genetics come. Ask family history. Somewhere uncle, aunts, mother, father, grandfather, grandmother, they are severely atopic. Someone has severe allergic rhinitis, asthma. They have suffered a lot during their childhood or as an adult. So this gives us a big clue. Yes, this child is in trouble because the genes have already come. That's exactly what is atopy. This child has the tendency towards developing allergies. This is the biggest pointer, family history. Second, severe atopic eczema not coming under control, and we do skin prick test or other allergy test, and we see that child is already sensitized to too many allergens, multiple allergens. Again, a big pointer that this child might not do well in future, especially if the eczema is not coming under control. You have to go to third, fourth stage to control, needing a lot of steroids, not coming under control. This is the child, and having clinically manifest already started manifesting food allergies. Foods are already causing him his eczema to worsen. You know that this child is already showing early signs of atopic march. Very likely that this child is going to develop allergic rhinitis and asthma in the future, because he has already shown allergic to many sensitization to many foods. There is strong family history, and food allergies are already developed by the child is 2-3 years. And we see this typically 7 months, 8 months, 10 months. Mother starts introducing new foods, child's eczema worsens. Very typical of atopic march. Food allergies have already come in. Okay, so these are the pointers which will help us to think. We have to keep our minds and ears and nose and throat, everything open, and make sure that the child is well controlled when this family comes to our clinic. A holistic approach needs to be given. Okay,
Great.
Dr. Neeraj, yeah, there is one
Dr. Deepti, one
question
more
in the
question.
chat. Yes.
Yeah, one more question to you. So that question I will ask later on, but one more question to you. Uh, there is enough literature, just correct me if I'm wrong, and I want your comments also on that. So there is enough literature that if a child with allergic rhinoconjunctivitis, if he is started on relevant allergen immunotherapy, then can you prevent the onset of asthma later on?
Very good question. So, see, exact to tell me quote a study would be difficult for me just now because allergic asthma and allergic rhinoconjunctivitis they almost come at the same time. It is known that allergic rhinitis develops first and stays on, and then allergic asthma develops. But in Pedicon 2024, my topic of the was United Airway Disease. So I had done a lot of literature search, and definitely the final conclusion of my talk was definitely it is a United Airway. There are so many, almost 12 to 13 mechanisms that interplay. So yes, if we detect our allergens for allergic rhinoconjunctivitis, we hit hard, we give immunotherapy, we do, I repeat, we do prevent allergic asthma. We
Thank you,
do.
Dr.
That was
Deepthi.
my talk last year.
Thank you, Dr. Deepthi. So this was a strong statement. That means, once again, I would like to highlight that we need to really think beyond eyes. We should not restrict ourselves only to probably improve conjunctivitis, but we need to think holistically, improve the child, improve the quality of life of the child, which is much more important. So now one question goes to Dr. Soundarya. Dr. Soundarya, are you around? Dr. Soundarya? Okay, let's go to Dr. Deepthi only. So, Dr. Deepthi, there's a question with the chat box regarding the probiotic use. What is your comment and what is your practice using probiotic for either treatment or prevention?
So now again, let's be very scientific. It's a national forum. Let's not put what I feel. Let's put what the research says. So now MRs come to us and they give us some probiotics to be used for, 3 weeks, 4 weeks, 6 weeks, 8 weeks. At the age of 10 years, you give probiotics, some bacilli, okay. Someone says GG, someone says something else, okay. For 4 weeks, 6 weeks. It's not possible to change IgE to IgG4 in just 4 to 6 weeks of some bacteria at the age of 12 years, 15 years you give. How is it possible? Do it and see. It's not possible. Give it for 6 weeks, 8 weeks. It doesn't happen. What does the research says? You remember I said primary and secondary prevention. So what is West doing? West is giving probiotics to mothers, pregnant mothers with strong family history and family history of allergies in the mother, plus family history in mother's family. There is a strong lineage, there is a strong atopy. Mothers are given probiotics in pregnancy. A good 3 months of probiotics in pregnancy, and that probiotic is continued in the newborn infant for another 3 to 4 months in infant, in the newborn baby. That time you are changing the child's immunity. That time you are building the good microbiome content in the child, which we considered is genetically lacking in such children and in such mothers. That's why kangaroo care, vaginal delivery, breast milk, all these in early life, when the allergens are, the allergies are developing, that is the time when we give probiotics, they do work. But some random and probiotic given some time in the life, person having severe vernal keratoconjunctivitis, and you give 6 weeks of probiotic sachets, please, it's not going to work.
Thank you, Dr. Deepthi. I think very, very nice, once again, explanation. So we need to really understand that all these probiotic studies, majority of them have been sponsored studies, and the results are seems to be, you can say, like more biased. And that's why the world authorities, that could be World Allergy Organization or American Academy, consensus statements or guidelines, they are not recommending probiotics, but one-to-one basis, sometimes some probiotic might be helpful, but there are no guidelines, there are no recommendations for now. In our personal practice, we are not practicing probiotics for any of the allergic patient at any of the stage. So this is our personal practice that we are not practicing. I am not practicing We are
Yes.
not practicing.
And we are not against probiotic, but let recommendations come. Let
Yes,
EAACI, World
let the
Allergy
recommendations come.
Organization, American Academy,
Absolutely.
let them put forward. We'll put it.
We are not against it, but we want more science. We want more data about it. Great. Dr. Paul, we can proceed further. Please unmute yourself.
Yeah. After an excellent session on this deep insights about ocular allergy, let's discuss about interventions in complicated vision-threatening conditions by Dr. Sugaranjini ma'am. She is a senior ophthalmologist at Girdhar Eye Institute, Kochi. We welcome you, ma'am. Please start your session.
I hope my slides are visible.
Yes, ma'am. Your slides are visible. You are audible.
Yeah. At the outset, I would like to thank AIOS
Ma'am,
and
you can make that full screen, ma'am.
yeah. At the outset, I would like to thank AIOS and the Indian Academy of Pediatrics Allergy chapter for giving me this opportunity. Some excellent talks, excellent points by Dr. Deepthi ma'am. Really an eye-opener, I could say. So my topic today is the surgical and procedural interventions in vision-threatening vernal keratoconjunctivitis. So when we talk about surgical interventions in vision-threatening VKC, we would mainly like to address the mechanical as well as the vision-threatening aspects of the VKC disease. In the mechanical aspect, we mainly have the giant papillary conjunctivitis, whereas in the vision-threatening aspects, we have the shield ulcer, which is caused by the mechanical irritation of the giant papillary conjunctivitis, keratoconus, which is a corneal ectasia, which is caused by the frequent eye rubbing, and limbal stem cell deficiency. So how do we address each one of these aspects individually? So when it comes to giant papillary conjunctivitis, there have been different modalities that have been tried. One could use a carbon dioxide laser removal of this giant papillae. This is a paper published in Canadian Journal, where, as we can see in picture 1, that the giant papillae have been reduced by the carbon dioxide laser removal. But the authors have reported a remission remission of giant papillary conjunctivitis up to 1.5 years. The advantage of this procedure would be that it can be repeated and it doesn't cause any subconjunctival scarring. Alternatively, one could use a cryotherapy, which is a freeze therapy, to reduce the size of this giant papillary conjunctivitis. This helps in shrinking the vascular core in the giant papillae. And again, the effects of the cryotherapy are short-term. It helps in short-term improvement only. And there is a recurrence noted, and it also induces some amount of subconjunctival scarring. This is a short video showing the method by which cryotherapy is given to the giant papillae. As we can see in this picture that there are giant papillae. So a cryoprobe, I would like to thank Dr. Shweta Agarwal for this video. And a cryoprobe is applied over the papillae and it is used to freeze the papillae, and these are the end results which are seen. Post-operative outcome is good, but it gives only a short-term improvement. So what are the other ways that we can address this giant papillary conjunctivitis? So giant papillae can also be excised. And there have been studies where simple excision of the giant papillae have been combined with mitomycin C. But unfortunately, in these studies, the recurrence of giant papillae has been almost up to 82.4%. And even the application of mitomycin C did not bring down the recurrence of the giant papillae to a large extent. There was still 57.1% recurrence seen in the giant papillae in a follow-up of around 1.5 years. So the next method that was tried was simple excision with cryotherapy and an amniotic membrane transplantation. It also had a recurrence of 12.5%, and the cryotherapy itself induced subconjunctival scarring. So simple excision of giant papillae with plain amniotic membrane transplantation was tried without the cryotherapy, and it did work wonderfully. And this was attributed to the anti-inflammatory property of the amniotic membrane itself. Though it did remove the mechanical effect of the giant papillae, and there was almost nil recurrence of the giant papillae seen in this study, where the follow-up was more than a year. The VKC symptoms, the symptoms of the vernal keratoconjunctivitis, such as foreign body sensation, itching, discharge, still did persist in these patients. So the other alternative tissue substitution, which was tried with a simple excision of giant papillary conjunctivitis, was a conjunctival autograft, where the authors actually placed a large diameter or conjunctival autograft from the same eye. And they did see a good improvement in the condition with almost nil recurrence of the giant papillary conjunctivitis and an improvement of the corneal erosions. But the recurrence of the giant papillae was noted in the areas beyond the graft, and this helped again only in the mechanical trauma. So the third option that we do have is a simple excision with mucous membrane grafting, and this has multiple advantages, and I will be discussing it in the further slides. So this, in the first picture is a example of an excision of the giant papillae as seen in picture A, which had a shield ulcer as seen in C, which improved with excision and amniotic membrane transplantation as seen in B and D. Whereas the bottom picture shows the excision of the giant papillae with a conjunctival autograft, which also gives a good result. So coming to this excellent article on mucous membrane grafting post giant papillae excision by Iyer et al. Like as a disclaimer, we have to look at the reasons why they considered a mucous membrane grafting in these patients. As we can see from this table that most of these patients included in this study already had at least 2 episodes of shield ulcer. And they had other associated comorbidities in the eye, like glaucoma, cataract. They had even undergone the surgery for the glaucoma. They had keratoconus. And the authors had tried every other modality available, like cryotherapy, tricot injections, before they deemed these eyes refractory. So it was almost like a last resort. So this is a video of the mucous membrane grafting. I would like to thank Dr. Shweta Agarwal again for this. And an incision is made, and then the area of the giant papillae as seen is excised completely. It is important to maintain the plane of dissection, and hemostasis is achieved. And once that is excised, the mucous membrane is taken from the lower lip and sutured over the area which has been excised. So basically the giant papillae is replaced by the mucous membrane, and this is the post-operative outcome. And as we can see that it is beautifully taking care of the mechanical factor. So mucous membrane graft is suitable because mucous membrane as such is structurally and immunologically allergy tolerant. And in this particular study, the authors have shown that there was no recurrence of shield ulcer in these refractory cases, even though recurrence of the giant papillae did occur in the areas beyond the mucous membrane graft. And the best advantage was that the patients could be weaned off strong steroids to control the VKC. And it also helped in saving the conjunctiva in cases of steroid-induced glaucoma. So now coming to shield ulcer, this is a grading of how we grade the shield ulcer based by Cameron. So in grade 1, the ulcer will have a transparent base, and these kind of shield ulcers will respond well to medical therapy itself, that is topical steroids and anti-inflammatories and antihistamines. But when it moves on to the second grade, that is grade 2, the ulcer will have a transparent or opaque base. This is basically collection of the debris there. So along with the medical line of treatment, a debridement with an amniotic membrane transplantation or a bandage contact lens to prevent further accumulation of the debris would help in healing of this ulcer faster. But when it moves on to the grade 3, where the ulcer is also associated with an elevated plaque, only a debridement with amniotic membrane transplantation would help. So this grading was suggested by Cameron et al. And Reddy et al. Have shown in their large case series of 193 eyes that as the grade of the shield ulcer increases, that is, as it moves on to the grade 3, medical management is not sufficient, and you will need to do a debridement with an amniotic membrane transplantation to help in healing of these ulcers. So in keratoconus, the mild and moderate cases can be managed with corneal cross-linking. But when it comes to keratoplasty, there have been multiple studies. Though in transplantation, we have the full thickness or the partial thickness transplantation available. That is the penetrating keratoplasty or the deep anterior lamellar. So there have been studies which have compared the outcome of this keratoplasty in patients with VKC and keratoconus and in patients with keratoconus alone. So multiple studies have shown that there have been comparable outcomes, but when a patient is undergoing a penetrating or a corneal transplantation in a patient of keratoconus with a vernal keratoconjunctivitis, what are the things that you need to watch out for? So you need to watch out for graft-related complications. That is, there can be an increased risk of graft failure, and they might have persistent epithelial defect due to impaired healing, and mainly suture-related complications such as loose sutures. There can be abscess formation, or there can be vascularization. And medication related, as you know, we will have to put them on long-term steroids, so they might have steroid-induced cataracts. So coming to the last point, the limbal stem cell deficiency. So around 1.2% of the patients with VKC progress to a limbal stem cell deficiency over a mean period of 10 years. So the limbal stem cells are seen in this brownish pigmented areas known as Voges limbal triad, which is seen Voges limbal palisades, which are seen around the cornea as pointed here. So what are the early signs of this limbal stem cell deficiency? So in early stages, you will just be able to see a stippled staining, loss of the corneal clarity and epithelial irregularity. But when moving on to the later stages, there'll be a corneal conjunctivalization and even superficial vascularization, persistent epithelial defects, scarring, and even melting of the cornea. So how does one address this? First, we need to know the risk factors first. That is, males have a higher risk of developing this. If the child has an early onset of the disease and if it is persisting beyond 16 years of age, then the child is more prone for limbal stem cell deficiency. And if there is more than 10 years of active period, disease period, even then that is a huge risk factor. So in limbal stem cell deficiency, we need to look at whether it's a partial limbal stem cell deficiency or a total limbal stem cell deficiency. In case of a partial disease, which is very rare because usually VKC is bilateral, but if a child does have a partial limbal stem cell, you can just excise and put a conjunctival autograft. The main advantage is that you would be avoiding systemic immunosuppression in this case. Whereas in a total limbal stem cell deficiency, since it's a bilateral disease, we may not be able to take an limbal stem cells from the same patient. So we might have to take an allogenic simple limbal stem cell transplantation from a cadaveric or a living related. And in such cases, we will need to put the child on systemic immunosuppression. So coming back to the first slide that I started with, surgical interventions for mechanical and vision. So as discussed, giant papillary conjunctivitis can be dealt with either a cryotherapy or a carbon dioxide laser therapy, but we need to remember this is just a short-term fix and there will be recurrence. Or you can excise the giant papillae with and add a tissue addition with either an amniotic membrane or a conjunctival autograft or mucous membrane grafting. The disclaimer is that only after your primary medical therapy has failed should you even excise such options. And mucous membrane grafting has shown to be more allergy tolerant than the others. Coming to shield ulcers, again, you grade it based on the grade. The higher the grade, only a debridement and a surgical option like a debridement and amniotic membrane transplantation would help in the healing. And in keratoconus, mild to moderate cases, after the allergy is well controlled, you can go in for a corneal collagen cross-linking or intrastromal rings. But in a severe case, if you're going in for a corneal transplant, you will have to control the inflammation adequately and always keep in mind the suture-related and the persistent epithelial defects these grafts are going to face. And limbal stem cell deficiency, do look into whether it's a partial or a total. In a partial, you can do a conjunctival autograft, but in a total, you will have to look for an allo slet, and there will be a need for a systemic immunosuppression in such patients. Thank you very much for your patient listening.
Thank you, ma'am. That was an excellent presentation. So for the questions, I would like first to ask Dr. Vrushali, ma'am. Ma'am, you are there?
Yeah. Yes, please.
Ma'am, regarding the first question that I wanted to ask, that regarding the giant papillary conjunctivitis, uh, regarding regarding the surgical management, what do you feel like? When do you go for this mitomycin C? When do you go for this cryopreserves? When do you go for this conjunctival autograft?
Personally, I'll work on prevention of giant papillary uh, before treating it. If we work at a root cause, then we can, prevent the giant papillae to increase. What we are talking about is by giving an uh, allergen avoidance and testing and immunotherapy. But once if you develop the giant papillary, yeah, I have managed with the biologics rather than surgical management. And along with that, we have worked at the root cause because just giving an any form of pharmacotherapy, maybe it's an omalizumab or any kind of pharmacotherapy, it will just reduce the inflammation. Once you stop it, it is going to come again and again. But if you work simultaneously to reduce the inflammation, but whatever method you use, even whatever the cryo and what you are treating it locally, but unless and until you work to prevent the further or to prevent you balance the Th2 inflammation that is going to recur. If you work simultaneously with the pharmacotherapy and to reduce the Th2 inflammation, I think that can take care of rather than going for the further surgical management. So in my practice, so I have control with all this, and I have never used the cryotherapy and all and caused the scarring of the limbs.
So, ma'am, like, what is then your go-to biologics? Like, what do you start with?
We are using mostly omalizumab with an 150 milligram, whatever is available right now in the India. Only for a one patient, we have given a 300, but other are responded very well with an 150 milligram of biologics. Most of them has responded at the fourth or fifth dose of biologics. They have complete resolution after fourth or fifth dose of omalizumab. From first dose itself, they have shows the there is a reduction in an giant papillae and improvement reduction in the inflammation. Even in a shield cell, there is a combination of an mechanical trauma as well as an inflammatory mechanism is there, and that is working at both levels. And then medically only we are able to control it. But same time we are introducing for a allergen avoidance as well as an immunotherapy, so that can take care of and further Th2 imbalance and reduce the inflammation in future.
Right. And ma'am, then what regarding this recurrence that you feel? Like, have you experienced recurrences once you are
So that is
stopping
what
these biologics?
if we work simultaneously at multiple level holistically at allergen avoidance, immunotherapy, and controlling the inflammation. So biologics that is controlling inflammation. But if you are giving only biologics, that is going to recur if once you stop it. But if you are working simultaneously with the biologics, the allergen avoidance, and immunotherapy, then that it shows in less recurrence chances.
Just if I can make a point here, like Dr. Vishali said, the local factors do play an importance, and like Sukuranjani has very beautifully highlighted in her talk. So, as ophthalmologists, I think most of us, I think Dr. Vanity and Dr. Vinay will agree with me on that. That most of the times, if it is only the eye which is primarily involved, and it is not too much of the other systemic factors, we go for a topical pharmacotherapy to start with. And if there are things which, on the ocular level, either a surgical intervention or a topical pharmacotherapy that can take care of the disease, we usually stop with that. If there is a systemic involvement or if we feel that the disease is becoming more severe, is when we have been referring. But like rightly pointed out in the webinar, that it's better to avoid and make sure that the disease does not reach that stage where it becomes severe. If we can intervene in the early stage itself, things can be handled better.
So one point actually I want to highlight here, even though eye is a primary organ, we should see the hidden signs of allergy in history, because whatever we are, Dr. Dipti has explained in our allergic march. So patient is not able to give an history in a childhood. So if there are the presence, all other hidden signs are there, then I think only eye or other, we should not wait to involve the other organ for the allergy testing and all. So that can be, every ophthalmologist should look for the hidden signs like in uh, hypertrophied turbinates and other signs of allergies.
Right. Shweta ma'am, final quick question. Yeah, like we talked about this primordial prevention. So just we had a quick discussion about the surgical thing. So can you give us, ma'am, like what is your take? Like we have this gradings for shields also at grade 1. We are doing this 2, 3, but we talked about GPC. We have a lot of things in our armamentarium. But do you give like when to give what surgically when the child is coming symptomatic child?
So a very valid question, Raj, and I think Suguranjani also in her presentation did brief us about all the different modalities of treatment with their pros and cons. If the papillae are not very large and we are seeing them, like it's just the first or the second visit that we are seeing, just stepping up the dose of topical steroids a lot of time takes care of them. If they are beyond that, then you go ahead with a cryotherapy. Excision with amniotic membrane is something that we really, as a principle, do not feel that has too much of scientific knowledge or scientific basis to it, because excision we do thinking that it is going to cause a conjunctival scarring, and amniotic has an anti-scarring effect. So it's going to take care, it's going to reverse the scarring that the excision is going to cause. And anyways, it's a basement membrane, so the conjunctiva is going to come and cover it back. So the tissue is back, the disease tissue is back. So there's not too much that we're going to achieve with excision with amniotic. And if the papillae are very large and they are the primary source, then we have gone ahead with excision with mucous membrane graft. And I think today Mukundan is going to be presenting a case which will give us details about that CVP. Dr. Vinay, you have something more to add on to it, or Dr. Panithi?
Well, nothing much, but then see, the surgical management for papillae is very different from surgical management for shield ulcer. Shield ulcer is practically an ocular emergency, which is quite, vision threatening, even blinding. Okay, so that is the basic difference between these two. Okay, shield ulcer, I mean, there is no doubt that in the later stages, surgical intervention is absolute must to get an ideal outcome. Papillae surgical, it's a little controversial, area, especially with the new, information or the newer, outcomes of the systemic management coming up. Now, surgery for papillae, we even think about it only once the disease process is managed and controlled well. Okay, what we are addressing here is the mechanical effect of the papillae. Okay. So if there is a treatment that is going to reverse the papillary changes, surgery will not be required. Okay, right? So there is preliminary evidence in the literature that managing them with the immunomodulators like immunosuppressives, or as a doctor was saying, biologics probably bring about a change in the tissue remodeling that has happened. Okay, so is that really working? We need further, much more evidence to say that it does as of now. But then the advantage of mucosal transplanters, we are doing it a one-time procedure. Okay, we are bringing in a tissue which is quite different, in terms of morphology and all the pathology there. Okay, which might be quite resilient to whatever is happening on the ocular surface. At least the practical experience is like that. Okay, it prevents the recurrence of the papillae. The number of recurrences of the acute episode reduces after the disease. So, yeah, it is a clinical, it's a clinical thing which we have experienced. But then, what is the basic mechanism there? It's still, it's still a little gray there. But then, definitely, we do have an advantage, or we find it useful in certain cases.
I think a wonderful discussion, beautiful discussion. Dr. Shweta, Dr. Vinay, Dr. Vishali. So, Dr. Shweta, I would like to say two things to you. One is about a compliment related to the classification which you made and I think that was very relevant. But one suggestion also. So what I feel, so like what I understand is that in the second stage you have added allergist opinion, but I can't see that in the third stage or the fourth stage. So my suggestion is that it should also be
No, no,
added
no, no,
even
no.
in.
One second, one second. No, no, no. One second. It is there. It is from the second stage itself. The referral to the allergist is there. I
Yeah,
think the version that Vinay sir has was the pre-edited version. So
no issues, no issues.
the final classification has referral to the allergist from grade two, from the moderate or the persistent cases. So 2, 3, 4.
Agreed. But what point I wanted to say is that suppose in stage 3 and stage 4, let's take an example. For that particular patient where we feel that probably the VKC or the disease has advanced to a stage where it might not be reversed completely, or it might be reversed only partially or whatsoever. But if you can say, like, if a allergist referral or probably a targeted allergen which may be found in a selected patient and an allergen immunotherapy may be started, then the next phase of the disease, which is probably asthma, might be prevented, right? I am going a little beyond, not remaining only to the VKC or not remaining only to the eye. I am just going to the child, that for that particular child, 2 years down the line, 5 years down the line, another disease, another doctor, another specialty might be prevented just by that. So that was my point to highlight, not only from the
So,
VKC point of view. Yeah,
no, so that's exactly, I point very well noted, Dr. Neeraj. That's exactly why we have included the referral of allergist directly from stage two. The
great, great.
minute from seasonal, it becomes a moderate, persistent, and persistent. From seasonal, the minute the disease becomes moderate to persistent, you have to refer to the allergist. So it's
Absolutely,
like,
absolutely.
every stage beyond that, there is a referral to the allergist. In fact, this is what I was telling them, that this change was made after the recommendation by allergists like you at the EARCI conference when I presented this work. So accordingly,
Definitely, definitely.
as ophthalmologists, we understand only when things become severe was the original version where we had referred to the allergist. But it was only after I presented the work there and the allergist in the audience pointed it out, and it looked like a very valid suggestion. So we modified that and we included it right from the stage two.
No, I was also actually fortunate to witness your presentation
Yes.
at Europe at that particular time. I was also one of the attendees there at your
Yeah.
presentation time. So that was really a very fantastic classification and the need of the hour. So now, as we have discussed over, you can say, like, nearly past 3 webinars, that a lot of different phases of eye allergy. The question is that Dr. Deepthi has also highlighted this question. The question is that can we prevent this debilitating disease rather than thinking about diagnosing and then treating and then biologic and then different other different things? Can we do something to prevent at a very early stage? So I would like to invite my colleague, Dr. Soundarya Mahalingam. She is a senior pediatric allergist and she is also professor at Kasturba Medical College, Mangalore, for her deliberations on the preventive and environmental strategies for ocular allergies. Dr. Sundarya, you are welcome. You can please start your session.
Thank you so much, sir. Thank you so much for the invitation. Thank you to the organizers. And thank you for bearing with me. Apologies for going offline during the power cut and heavy rains here. So I hope the next 20 minutes will be good to go. So today's session is on prevention strategies in ocular allergies, essentially translating to allergen avoidance measures. So, allergen avoidance, what do we mean by allergen avoidance? Usually, the word allergen kind of makes it seem as it's only house dust, mite, cockroach, pollens like that. But as Dr. Deepthi has pointed out, it's not only allergens, it is triggers that are important. And the triggers will be both. You can have allergens, you can also have irritants. So, avoiding both of them goes a long way in the management of allergic conjunctivitis. So, which are the allergens which are primarily responsible, which you have heard over these 2 years? I'm just doing a recap. The house dust mite, pollens, pet dander, mold. These are the four main allergens which are responsible for the allergies and ocular allergies. Which are the irritants? We have indoor and outdoor pollutants. We have topical cosmetics and contact lenses as a small proportion. Now, let's begin with house dust mite. Now, the preventive measures for the house dust mite will be divided into two. One is measures which we take inside the bedroom because the house dust mite primarily lives inside anything soft, be it mattresses, be it cushions, be it any furry toys, carpets, anything soft. It stays there in humidity and warmth. So, what are the measures we take in the bedroom? Removal of carpets, avoid velvety soft cushion covers, sofa covers, removal of stuffed toys from bedroom, washing all linen, be it bed or cushion linen, in hot water weekly. When we talk of hot water, we're talking of something around 140 degrees Fahrenheit or 65 degrees Celsius as per the washing machine standards. And this is because the house dust mite lives comfortably below 45. So the 35 to 45 degrees is a very comfortable time for the house dust mite. It stretches up to 55 for the house dust mite particles. So dislodging of the particles and removal of the fecal particles of the house dust mite best is done when the temperature is above 55, around 65 degrees Celsius. Sun drying of bed mattresses. Yes, that's a very good option every Sunday. Bed mattresses to be sun dried in the hot sun because that is another thing. The warmth and the damp environment which the house dust mite loves to thrive in, that is removed when you sun dry the mattresses. But yet, in a place like we are in the coast, right now we have been having 3 months of rain. There's no issue of question of sun drying here right now. Mite-proof covers. Now, there's a lot of literature available on mite-proof covers. Mite-proof covers are essentially very, very tightly woven thick covers, which are so tight in their thread count that the fecal particle, which is around 0.03 micrometer, that does not come out of the thick threaded cover. Now, these covers are lots available on the internet. However, the really good covers are expensive and it's very difficult to have the entire house mite-proof covered. But yet, it does play a role when we have less number of bedrooms and single bed, single cushion. Yes, in those places, it does help. Whole house to change, it is not very useful and not very feasible as well. Using feather pillows rather than synthetic, as covers of feather pillows are tightly woven. Now, this was what I found in literature, which had certain Cochrane reviews also. However, this also has a plus and minus point. Using of feather pillows has its own disadvantages, especially when the covers have to be removed. The feather antigen can be displaced all over the room. So, this is plus minus, but yes, this is available in literature. Goose feather pillows is what they have said and the tightly woven covers, and the cover is not to be removed. That's almost similar to mite covers. What measures you can take in the whole house? Vacuum cleaning. Now, vacuum cleaning is good. However, the mite antigen is very small. So, vacuum cleaning is good when we're done with a HEPA filter at the exit of the vacuum, where the vacuum draws in the dust of the mite, and yet the exhaust which drives out the blown air has a HEPA filter there. So that time the entire small fecal particle and their antigens are not totally dispersed over the room. This helps to reduce dust disturbances, yes, should be done with a HEPA filter and best done when the child is outside the house for some period of time. The HEPA filters, what are they? They are high frequency particulate absorbers. This helps to absorb these 0.3 micrometer particles. And if put up the exhaust, it's not only the visible dust which collects in the dust bag, even these small particles which are invisible and finally land up getting spread all over the room, they will also be blocked at the exit. So that is very important. HEPA filter at the exit of the vacuum. Humidity control, best done if you have options of humidity control in the air conditioner or in the environmental situation. There, yes, if the humidity can be maintained to below 45% or less for at least 22 hours a day by using dehumidifiers, then yes, that also goes a long way in reducing the mite concentration and terminating the mite. Other measures are using wet mopping rather than dusting so that the mite particle is not, the fecal particle is not made airborne. Once it's airborne, though it does take about 30 to 45 minutes to settle, but in that time, the child can inhale it. And as the child plays in the evening and night, these airborne particles will tend to trigger the ocular allergies. Always remove or avoid upholstered furniture or thick curtains. When we talk about upholstered, they are the thick, soft fabrics with a velvety cover. So to avoid this kind of furniture covers and even thick drapes, it's better to use vinyl or rexine covers or blinds, which are totally waterproof, so they even don't let the mite antigen through. Use of acaricides. Now, this was another thing in literature where there was a lot of data. Acaricides in some places have helped, but however, it's a highly temporary measure. So at that time, we can use the acaricide, the mite concentration will come down. However, the mite concentration has been known to go back to the pre-existing level over a span of even less than a week. So acaricides are not very useful. They're useful for a single point use in conjunction with other measures. Use of air purifiers. Now, this is the hottest topic nowadays, use of air purifiers. Now, this with respect to the house dust mite antigen is very questionable because this is the antigen per se, though it gets airborne, it remains airborne only for 30 to 45 minutes. So because of the short airborne period, the air purifier has to run the whole day for catching that short airborne period. Otherwise, the mite antigen tends to settle back down on the mattresses, curtains, carpets, etc., which is where the children come to in the evening after school, sit, play, jump, and again cause all this antigen to be blown up into the air and inhaled. So air purifiers are not the best option, but yes, if required in conjunction, yes. So with all this evidence, when we looked at multiple Cochrane reviews, what is the collative evidence? The collative evidence in so many reviews, they say that finally, multifaceted, individualized, home-based comprehensive avoidance measures should be used, and these have consistently demonstrated a significant reduction in the house dust mite allergens. However, the caveat also is there. Maintaining this practice is what is most important in achieving success in any type of allergy, including ocular allergy. And that is where the challenge lies, in maintaining this practice over time, doing all these type of approaches. Now, from house dust mite, let's move to molds. Molds are essentially the fungal colonization, especially when there's dampness. So the best way to avoid mold is to avoid dampness, seal leaks, which is easier said than done, especially in huge apartments. Very difficult to avoid dampness and seal leaks. Dehumidifiers can help, especially the ambient humidity is more because humidity helps to increase the mold growth. Improving ventilation and light in basements. Now, in basements is where there is dampness, there's water logging, there's seepage, and they are the places where nobody actually focuses and goes. So, improving ventilation and light will also help to reduce the mold growth there. Avoid use of saunas and pools till the allergy is controlled and the mold source is treated. Because again, these are all places where there's water, there's dampness. So even small amount of molds can be there on the ceilings, and the walls, on the sides, and all this release millions of spores into the air. And all these are inhaled, and that trigger the mold allergies. They can go into the eye, trigger ocular allergies. That's treatment of the mold source is important with removal of this damp material. Clean the area with chemicals which are anti-mold and use of HEPA filters in the exhausts. These all help to prevent the spores being released as well as purify the air in the middle. There's another measure which has been found to be useful is reducing the plants and soil in the house. This works counterproductive in certain ways. We also say plants are useful in the purification of air, and many of them do remove a lot of volatile organic compounds, etc. So when we use the plants, and we also have to reduce the plants and soil, which means you will have to circulate the plants what we're keeping inside the house, and this circulation helps to ventilate the soil and that prevents the mold growth. Constantly keeping a single plant in the bedroom causes the mold to grow on the surface of the soil. Now, what is the collative evidence of all the measures I listed? Now, Cochrane reviews have said that good mold control has multiple benefits. And when this is combined with multifaceted approaches by controlling all the other triggers like environmental tobacco smoke, house dust mite, and other causative allergen, it does go a long way in managing allergies, including ocular allergy. Coming to pollens. Now, pollens are larger, a little bigger set of allergens. They are 20 micron in size, so they are essentially going to be deposited more on the eyes and the nose, contributing to allergic conjunctivitis, ocular allergies, as well as the allergic rhinitis. They are very rarely going to be triggering lower airway allergies unless it is a combined airway concept. So, because of that, use of masks, especially which cover the mouth and the nose. Which masks? We're talking about the N95 masks where 95% of the particulate matter less than 2.5 micron will be avoided from getting inhaled. Nasal irrigation can be done regularly using normal saline or even hypertonic saline. Now, when I read this, whether this is only useful in allergic rhinitis or it's useful in ocular allergies, I read that it has a good role even in prevention of ocular allergies because as the pollen gets deposited in the nose, the same unified airway and the connection between the eye and the nose, the inflammation gets triggered. So yes, nasal irrigation, which is done for removing the pollens which can get deposited in the nose, also has a role in preventing ocular allergies. Bathing after coming from outside, this is to remove whatever is deposited on the face, on the nose, in the eyes. Following pollen forecasts, staying indoor on high pollen days so that you reduce your exposure to the trigger. Staying indoors during thunderstorms because thunderstorms help to break the pollen particles and make them more allergenic. Reduction in pollution exposure. Pollution and pollen work together. And which pollution are we talking about? Especially when it is exposure to diesel exhaust particles. These particles help to bind the pollen and carry the pollen into the nose and deposit on the eyes and go into the lower airways. So reduction in pollution exposure to what best possible also helps to reduce and help patients on pollen allergy also. So looking at all, these are all the measures available. So what is the collative evidence? The collative evidence of the Cochrane and the systematic reviews I read, they said these outdoor allergens cannot be avoided completely. For allergic individuals, closing doors, remaining indoors, using air conditioning may be beneficial in reducing their exposure and hence managing their ocular allergies and preventing up flares. Coming to pet dander. Now, pet dander is the cat and the dog. The pet which comes from the mouse and all are even still newer, but yes, they do exist. Hamster, guinea pig, mouse, all these are the newer pets which are there. So, removing carpeting and upholstered furniture because all these allergens are easily airborne and they settle down and they are sticky, settle down on the carpet, settle down on the upholstered furniture, from where again when the child comes and sits, they again get airborne and they go again, get topically touch the eye, enter into the nose, etc. Vacuum cleaning, similarly with HEPA filters at the exit, because this also can help the allergens from getting trapped inside and not again getting airborne. Removing the pet if possible, yes. If the allergist has proven that the ocular allergy is because of the pet, removing the pet will go a long way. But however, all studies have said that this is very difficult because of the relation the child has with the pet. So it's only up to a point as to how much the child is willing to part with the pet. It is difficult, but yet it is a measure. Regularly washing the pet. Now, this has been done primarily with cats and dogs, where the regular washing of the pet has been suggested as an option. Where because these particles are on the dander is the epithelial scales of the animal. So, washing helps to remove those epithelial scales. So, regular washing of cat and dog might be possible, but regular washing of guinea pig, hamster are very, very difficult. But yes, these are all measures suggested. Air purifiers may help, and especially when it comes to the case of the FEL-D1, which is the cat dander antigen. Now, this antigen is a sticky antigen, it's airborne, it's light, and so air purifier will immediately suck it inside and prevent it from getting back airborne. So, the cat antigen, which is light and spread over long distances, yes, air purifiers can help. There is nothing like a hypoallergenic breed. There are advertised many breeds like hypoallergenic breeds. Fur is less. This whole concept of pet dander has nothing to do with the fur per se alone. It is nothing that dogs which have short hair or cats which are got only the Persian cats which have long or the Siamese cats with long hairs are the ones which are more allergenic. There's nothing like a hypoallergenic breed, and such concepts should not be advised. Neutering or staying of pets because of the concept that male cats produce more of these antigens. They do help, but however, most reviews said this does not help in isolation. This is all in combination. So keeping all these points in mind, what did the collective evidence come about? Here again, multifaceted approaches, including frequent washing of the pet, cleaning of the house, using of bed covers, along with appropriate control of the allergy, management of the allergy itself, is the conclusion for controlling allergies in pet dander exposure. Now coming to the last section, which is the irritants, which I had discussed. Now, among the irritants, the main irritant which has come about in any allergy is tobacco. So, tobacco cessation is a level A evidence that in controlling allergies in the family, tobacco cessation does go a long way. To avoid all the similar, the slide I saw with Deepthi ma'am, avoid all the indoor pollutants, be it the coils, the air fresheners, the sanitizers, the agarbatti, the mats, the sprays, insecticide sprays, the volatile compounds for painting and using the Duco furniture, which is very popular nowadays. Avoiding smoke, be it tobacco, be it the biomass fuel burning and the firewood smoke. Avoid contact irritants. These do have a small role to play, albeit not a large role, a small role to avoid these contact lenses and use of cosmetics in the eye, which is very common. So putting all of this together, now when we have a child with ocular allergies and the allergist has identified the allergen, what is the correlative evidence finally? Ocular allergies, what all I found, they said that there is no single measure which is sufficient for allergen control. So multifaceted approaches are needed for effective removal of allergens and triggers, and that will help to achieve good allergy control. Now, this is in conjunction with appropriate, adequate management and control of the allergy, be it with anti-inflammatory or biologics, whatever it is. The control of the allergy, along with multifaceted allergen avoidance measures, are needed for a final holistic good outcomes. So, with this, I conclude my talk. Thank you so much for the opportunity. Thank you.
Very crystal clear talk, Dr. Sundarya, as always. Very brilliant. Just only one question to you. You have already mentioned about the multifaceted approach and the different things should be done together. So now, if I just want to ask you that, because we understand that for perennial allergic conjunctivitis, dust mite seems to be the most probable cause. So if somebody asks you that what should be the one single intervention which seems to be most beneficial, though we understand the multifaceted is definitely the key, but still one single intervention, if somebody asks, then what should be the most beneficial?
So the most beneficial and the most feasible has been found in the hot washing. So proper hot washing of the covers of the bed, which is most feasible for us to remove the mite allergen from the bed and bed covers, removal of all these carpets, bare minimum cushions and soft stuff in the house. This is feasible and goes a long way in reducing the mite allergen in the house. If they can afford, then yes, dehumidifiers, vinyl covers, yes, they all go a long way. Most feasible, what I have seen among what the patient population which I deal with, most feasible is hot washing, sun drying of mattresses. That has been most feasible. And the single measure which anybody, no matter which strata of the society they come from, they can do is nice hot washing of the covers and sun drying of the mattresses.
So absolutely, but we need to really understand that the dust mite itself, it is not living inside the bed sheets. It is basically inside the mattress. So whenever the dust mite, which is, you can say, like the stool particles or the poop of the dust mite, which is more allergenic. So this stool particle or the poop which is coming up in the bed sheet, and when you are washing it in the hot water, especially at a temperature of 60 degrees Celsius or 65 degrees Celsius, you are actually denaturing the protein in the poop material, but the dust mite is not getting reduced. That we need to understand. So the dust mite reduction itself will require certain other measures. So one is about the sunlight exposure. Now the sunlight exposure, there is a catch. So you told that for past 3 months in Mangalore, the sunlight exposure is not great. So practically it is difficult. Then sometimes with this foam mattresses, the dust mite loves to go deeper inside. So even if you expose them in the, you can say, like the sunlight, but that will not work. So cotton mattresses are more better. If you just remember, you can say like cotton mattresses put in the sun every month, or every, you can say like 15 days, or every probably 2 months. So that usually do the trick, because the cotton mattresses do not have those hollow pores inside, that sponge inside. So that space is not there for the dust mite, and ultimately that goes away. So as per one study, it has been seen with these foam mattresses. So whenever somebody is buying a foam mattress, let's say that the new foam mattress is somewhere around 5 kilo. Let's take an example, arbitrary example. So 10 years down the line, it is said that the foam mattress weight doubles. So it becomes like 10 kilo. And the extra weight, 80% of that is because of dust mite. So we usually recommend that every 6 to 8 years, if you just change their foam mattresses, every 3 to 4 years, if they change the pillows, so that actually reduces the significant chunk of, you can say like the dust mite, which is there. The other important thing which you very beautifully highlighted about the air purifiers, and just 1.1 line which I just mentioned, want to mention about air purifier, that every air purifier is not same, right? So every air purifiers depends upon a lot of factors. It also depends upon that where you want to put the air purifier, which room. So wherever somebody wants to buy an air purifier, that room dimensions needs to be taken, and then length, breadth, and height. And then these dimensions needs to be provided to the vendor, that okay, these are the dimensions, I need an air purifier for it. And ultimately he will calculate a CADR value, which is clean air delivery rate. That is depending upon that how many air exchanges are there per hour for that particular dimension. And these air exchanges should be 4 to 6 air exchanges per hour. So it's not possible that you first buy a machine and then wherever you want, you just put it there. So it's not possible that way. So then there are other factors like in air purifier also, there's a gradings are there, which is called as minimal efficiency rating value, MERV. So depending upon that, what is your purpose? If you want to, you can say like use it for allergies, then at that time you will require an air purifier with the MERV value of more than 17. If you want it for some industrial purposes, then at that time the air purifier with a value of more than 12 will also work. So that is why what I'm saying, every air purifier is not same. Every air purifier, every machine is different. And you rightly mentioned that it is a dehumidifier, but I would like to say that beyond dehumidifier, the main aim is that you want to reduce the humidity level and keep the humidity level in between 35 to 50. So there are certain areas in the world, like probably certain areas in USA, Colorado, and some other areas where the humidity level is 0%. Then at that time you require humidifier. You will not require dehumidifier. You will require humidifier. In India, especially the coastal areas, Shweta is sitting just next to the sea. So the humidity level is 90%, 100%, somewhere like that. So you will definitely require dehumidifier. So target is not dehumidifier. Target is that the relative humidity level should be somewhere in between 35 to 50%. That should be the target, which should be there. But I think a very beautiful discussion. So with this, I would like to say to Dr. Paul that we can probably move to the case discussions.
Right, sir. So thank you, sir. Thank you, ma'am, for this enriching talks. So now we have reached the last two case discussions. Let's have a first case by Dr. Gundan. He's a trained cornea fellow from NV Prasad. He's now working at Cornea and Ocular Surface Department as an associate consultant at Shankar Nethralaya, Chennai. He will be presenting a case of refractive vernal keratoconjunctivitis, highlighting the surgical management.
Dr. Neeraj, we can't hear the video. I think you
Yeah,
have to
so
play it again.
Hi everyone, I'm Dr. Kundan,
yes.
Associate Consultant from Dr. G.
We
Petalakshmi.
still can't hear it.
Okay.
It's audible, ma'am.
Hi everyone.
Is it audible?
Kundan, Associate Consultant from
Yeah,
Dr.
it's
G.
audible. It's audible now.
Yes, sir. Audible.
Check. I would like to thank Indian Academy of Pediatrics Allergy and Applied Technology Chapter
Dr. Neeraj, we still can't hear it.
and Dr. Shweta for giving me this.
Dr. Shweta, I think this is audible, but the voice recorded itself
You are
is.
also on mute, I think.
Just have a look.
Move on to okay. This is about a 9-year-old boy.
Is it okay now?
Yeah, now we can hear.
And photophobia. On examination, his breath-corrected visual acuity was 6.9 both eyes. Upper palpable conjunctiva at Jane Pratilate and both eyes cornea at superficial punctate paralysis with left eye shield ulcer. Intraocular pressure was normal and fundus examination was normal. Patient was diagnosed with both eyes active PKC with shield ulcer in the left. Left eye epithelial debridement and B-film was placed. They were started on a short course of topical steroid. Allergy specialist review was done and no systemic allergies were found and skin prick tests were found to be negative. On subsequent follow-up, left eye shield ulcer healed well and he was put on both eyes stacked with iron. However, at 6 months, despite being under regular care, the child had become steroid dependent. Any attempt to taper steroids below twice a day resulted in recurrence and large dorsal ganglion still persisted despite patient on steroids. At 1 year, the parents reported that if the steroids were reduced below 3 times a day, the disease would return. Thus, over the next 6 months, he continued to have multiple similar episodes. At this point, the diagnosis of refractive BKC was made and was planned for mucous membrane graft in 4 types. This is the picture post mucous membrane graft in both eyes upper dorsal content. At 3 years post mucous membrane grafting, the patient was comfortable with both eyes quiet and he was completely off steroid. He was maintained only on tacrolimus ointment and olapatide drops. Just to summarize, a 9-year-old child with active BKC and left eye shield ulcer on dual-acting anti-allergics and short course of topical steroid and tacrolimus. At 6 months follow-up, he became steroid dependent. Disease would better, steroids were taken below 2 times a day. At 1 year follow-up, multiple episodes of recurrence of the disease activity and hence planned for mucous membrane grafting. Post mucous membrane grafting, there was no recurrence of the disease. He was off steroids. Advantages of mucous membrane graft being actually different. The Langerhans cells of the oral mucosa differ both phenotypically functioning from those on skin or nasal mucosa which are capable of initiating anti-inflammatory signals. They also decrease the bulk of increased tissue and its underlying problem, that is reducing the frequency of episodes. Thank you. You all are welcome to explore a ocular surface growth channel, your ultimate resort to explore the answers of ocular surface disorders and surgery.
That was wonderfully managed, Dr. Mugundan. So a very quick question to Dr. Vanati ma'am. Ma'am, you saw this refractory case. The child was having recurrences once the steroids were tapered. So it was managed with a mucous membrane graft. What would have been your take? Like, what different thing would have you done surgically or medically in this particular case, ma'am? Quick comments.
Yeah. I think in this particular patient, considering that the patient has been refractory to the conventional management modalities for over a year and was also becoming steroid dependent and was going in for a blinding disease, which was also affecting the cornea, then an aggressive intervention in terms of a surgical excision with a mucous membrane is probably justified in such a scenario. But I usually refrain from a surgical intervention modality and started giving tacrolimus ointment 0.1% over the lids. I give on the skin of the lid applications for these patients, especially pediatric patients. What I do find is that pediatric patients are not compliant with using your immunomodulator therapies topically here. And the commercially available cyclosporins will not work given the amount of inflammation you're seeing. So probably you would need to step up your topical cyclosporins to maybe 1% or 2% if you're looking at containing or using a long-term immunomodulator therapy for these chronic infections in terms of topical therapies required here. And I find many of these children are not compliant at all. So then we have started using tacrolimus 0.1% eye ointments as an application over the lids, over the skin of the upper eyelids here on a twice daily application. And I do find that at the end of 3 months, most of them, they show good reduction in about at least 80% of their symptoms go down here. But I do find that some amount of them closer to the where we evert the tarsus, the papillae tends to remain. Whether that is because of the way they are spreading the ointments over the upper eyelids and they're not probably going more posterior towards the furnaces is something which which is what I think about it. But most of the times I refrain, and I do find this is a more tolerable and a compliant therapy to which these patients have. And I also tend to put them on low potency surface steroid ointments like loteprednate. And alloteprednate once daily dosage, and again started early on before you get your disease to go on to such a frank, when your surface inflammation has mounted to such a level, then you will perhaps need to debulk the surface. And as was rightly discussed earlier, what you're actually doing is you're trying to debulk the mucosal tissue which has so much of inflammatory reaction, so that you're probably giving a better surface. And I do not know how long this is going to be quiescent, or whether it's not going to allow a subsequent recurrence in these children. Again, I do find this profile or this group of children in which this tends to occur tend to be quite, their response rates, their compliance rates to treatment modalities, to follow-ups generally tends to be poor in this group of patients as well. And again, perhaps this is the group of patients in which you could probably start this is probably a take-home message for me as well from what Dr. Neeraj and the other discussions, is that this is the group of patients in whom an early on starting systemic immunomodulator therapy is perhaps going to be much effective. And I think that's a very good suggestion here, because I do find this refractory group, nothing really works, and you have to put them on a very high level of and you mix and match and then wane them starting from a higher potency, bring them lower, and many of them tend to be steroid responders as well here. And so perhaps this is the group of patients where I would probably want to start them early on systemic therapies here. So I would like to ask Shweta one thing, because I have not done a lot of MMGs or excisions of GPCs. And I think those were fantastic results which were shown here. But in terms of, again, I think there is a learning curve to it, because they have to know the plane at which they're going to do it. Otherwise, I think it's going to result in more trauma than helping. It's going to cause a significant amount of scarring there, which is really going to damage. So I think well done. It is really good. But just a question or a query from my side: how much of subepithelial fibrosis or subepithelial scarring do you really see, and how does this really affect the ocular surface? Tear resurfacing, in terms of how do their corneal staining, conjunctival stainings behave subsequently? Does it really affect your the dry eye disease? Because we do know it's a lot of the accessory lacrimal glands which are embedded in the conjunctiva, which is really helpful for the lubrications. And of course, the MMGs can help to a certain extent, but then they are really not physiologically closer to mucosa, to conjunctival mucosa.
So very, very valid points, Dr. Vanati. Actually, uh, yes, the main aim of replacing a mucous membrane graft in place of conjunctiva is that you are replacing a diseased tissue with an immune tolerant tissue. The tissue is being replaced in the tarsal surface, where we usually do not have our accessory lacrimal glands. And since the plane of excision is superficial, you do not expose the meibomian glands or the tarsal plate. It is just the papilla which is being excised, and the whole raw surface is covered with a large mucous membrane graft. The only thing is it has to be really thin. If it's too bulky, then obviously it will cause ptosis and abrasion of the surface. But otherwise, a thinly done mucosal graft does extremely well. Since it's immune tolerant, it is histologically and structurally very different from conjunctiva. So it's debulking the diseased tissue. And the like in an amniotic, it is a conjunctival epithelium which covers it back. In the mucosa, it is the mucosal epithelium which remains. So we have had patients now with almost 9 years of follow-up, where there has been no recurrence at all in the area that we have done the grafting in. And in fact, because the bulk of the disease tissue is reduced, the frequency of their episodes, the need for topical steroids has significantly reduced. So for us, what we have learned in all these years is if there is a systemic component. So in this patient also, we had referred the patient to an allergist to rule out if there is a systemic component. So if we have ruled it out and the allergists tell us that no, systemically the child is absolutely fine, there is nothing that is contributing, and we still have these large giant papillae, then we go ahead and excise them and replace it with a mucous membrane graft. But if we do have patients where there is a systemic component, then we co-manage it with the allergist, and with the systemic therapy, the immune therapy, or whatever they decide, immunomodulator. If things get better, then that works the best.
And this patient was already on topical tacrolimus, ma'am. This patient was started in the first visit only, but 0.03% he was on topical tacrolimus from the first visit. But still, in spite, he was having a recurrent. That
Yeah.
it was a refractory chain papillae.
Okay, that's something I do find a 0.03. Of course, that's the tolerable dosage which we have here applying, but a 0.1 applied over the lid, I do find really works and really helps to, reduce the inflammatory change, and the compliance is also much better.
Yeah, thank you, ma'am. Excellent presentation, Dr. Mukundan. So we move on to our last presentation that will be by Dr. Shivani Joshi. She's a trained cornea fellow from AIMS, and she'll be presenting a chronic case of vernal keratoconjunctivitis with complications. So here is the video.
Give me a second.
I agree.
This is one second coming as a wrong one. Give me a second.
Welcome, Dr. Shivani.
You are mute, doctor.
Good to see you.
Oh. Somehow that video is not coming up.
Should I play it from my thing?
If you have, so that will be great. So Dr. Shweta, we cannot hear that. You need to change the voice setting.
Is it audible now?
No.
No, ma'am.
No.
No.
The video is playing, but without the volume.
Okay, 1 second. I'll share it again. Is it okay now?
No, the voice is not coming.
No. No.
Okay, 1 second.
History of similar complaints
Now
since
is
11
it
years of
coming?
age that
Yes,
Yes,
it is
yes.
fine. It's fine.
It's fine now.
exacerbated during the summer from RP Center for Ophthalmic Sciences, AIMS, New Delhi. And today I'm going to be presenting a case of a 15-year-old boy who's a resident of Bulandshahr, Uttar Pradesh, who comes with the chief complaints of redness, itching, and watering in both eyes for the past 20 days. There's a history of similar complaints since 11 years of age, that is for the last 4 years, with symptoms getting exacerbated during the summer and spring season. When the patient first presented to RP Center 2 years ago, he had similar complaints and was diagnosed with both eye vernal keratoconjunctivitis and started on a medical management of a low potency steroid, immunomodulator, and dual action anti-allergen. He was lost to follow up after that, and 1 year ago presented with a shield ulcer in the left eye, which was managed by performing the multi-layered amniotic membrane graft. He was lost to follow up again, but now came with the complaints of itching and discharge from both eyes. But this time, right eye was worse than the left. Systemic examination was within normal limits with no signs suggestive of atopy. On ocular examination, visual acuity was 6.9 unaided in the right eye with 6.9 with the existing glasses, 6.18 unaided in the left eye with 6.12 with the existing glasses. On cycloplegic refraction under home atrophy, patient had a compound myopic astigmatism, minus 0.5 diopter sphere with minus 1 diopter cylinder at 90 degrees with the acceptance of 6/6 in the right eye, minus 0.75 diopter sphere with minus 3 diopter cylinder at 90 degrees with an acceptance of 6/9 in the left eye. The intraocular pressure and non-contact volumetry was 12 and 13 millimeters of mercury. The globe was normal in shape and size and axillary position. The eyelid in the right eye showed mild ptosis with no other significant finding. On conjunctival examination, there was presence of ropey discharge, and in the upper tarsal conjunctiva, as we can see in these clinical photographs, there was giant papillae which was present in the right eye and there was no scarring. In the left eye, there were active papillae again and there was no scarring. In the cornea was normal in shape and size with clear no opacities in the right eye, while in the left eye, there was a 3 into 3 mm nebular corneal opacity in the supernasal paracentral cornea. The sclera, anterior chamber, iris, and pupil were within normal limits. The lens was clear in both eyes. The fundus as well was within normal limits, with the disc being healthy, with a cup disc ratio of 0.3:1 and the NRR was pink and healthy. This becomes important because patients of vernal keratoconjunctivitis are usually kept on steroid treatment if it is severe, and it is important to rule out any sign of glaucomatous changes or any lenticular changes in these patients. In the right eye clinical photograph, we can see the presence of a conjunctival prolapse in the upper lid, probably because of the presence of the giant papillae. And in the left eye, we can see the presence of the supranasal paracentral corneal opacity, likely because of the shielded ulcer in the left eye. Dry eye workup was done for both eyes, which showed the Shermer test of 20 millimeters at 5 minutes in the right eye, 18 millimeters at 5 minutes in the left eye. Tearfilm wake-up time was beyond 10 seconds in both eyes. The NEI scoring of the conjunctiva was 0 out of 18 in both eyes, and the cornea showed punctate staining of 5/15 in both eyes. We went ahead with investigations and did a Schemfeld-based tomography of the right eye, showing a flat keratometry of 42.3 and a steep of 44.3, with the maximum keratometry being 45.6 and thinnest local pachymetry being 591 microns. The map shows a asymmetric bow tie type pattern with inferior steepening. In the left eye, there is a quality score which is abnormal, showing some data gaps. So we can't
The audio is gone.
giant papilla in the right eye was made with left eye shield ulcer, which is blinding stage according to the Gokhale staging. Medical management was started for this patient with cold compression 3 times a day, avoid eye rubbing, eye drop, difluprednate 0.05% VD for 3 weeks in the right eye, dual action anti-allergy, golopatidine hydrochloride 0.7% OD, so eye drop cyclosporin 0.09% VD, loteprednol eye ointment, tacrolimus eye ointment, HPMC ointment, as well as a CMC 1% drop and sodium permoglycate drop, HS. Patient is on follow-up and is planned for a repeat pentagram to capture good maps. Thank you.
Well-managed case, Dr. Shivani. So is the patient currently still under the follow-up?
Yes, he's still under follow-up. He's yet to come, and the giant papilla have responded to the difluprednate at present, but we will have to taper the dose soon. So it's just been around 3-4 weeks since we stopped.
So before ending, Shweta ma'am, your any final comments over the case that we just saw?
Oh, I think it was a very well managed case. I think Dr. Vanity wanted to add a few points on this, so we can hear it.
Yes, ma'am.
I think that one of the features which we should always reiterate when we are managing, especially pediatric ocular allergy, is the emphasis on not rubbing the eyes. So that's a specific risk factor for these patients, and they probably develop the corneal disease, which is secondary to the constant eye rubbing, which is there. And I do agree that it's very difficult to contain that in the pediatric patients here. So this is here where probably systemic therapy is also going to help in such patients here. So regular follow-ups, it's also important in terms to look at the corneal curvature progression in these patients. And several times it tends to get missed. And by the time they pick it up late, then the refractive rehabilitation becomes difficult in these cases here. And that's an emphasis besides the compliance to treatment, besides counseling the parents that these children need to have a continued follow-up with us is something which is imperative. And I think it's also important for corneal physicians to also take a look at the secondary morbidity features in terms of steroid-induced cataract, steroid-induced glaucoma. Many of them tend to have associated myopia, tend to have associated be steroid responders in these cases here. So these are factors which, looking at the fundus, watching the lens also needs to be emphasized in terms of whoever is the corneal physicians or fellows who are looking at these patients regularly.
Right, ma'am.
One last thing. A lot of times it is not just the topical, but the systemic
Yes.
sources of steroids as well. So a lot of times these inhalers that are being given to people, a lot of time the steroid inhalers that are being given to children for the asthma or for the rhinitis also contribute to the ocular complication.
Yes.
So, our allergists and pediatric friends should also be aware of the possible complications of systemic steroids. So even if oral steroid tablets that are being given, a lot of time induces cataract in children. And the problem is, by the time the children identify that, they are not able to see, so it could be one cataract would be more in one eye and than the other. And they often are amblyopic by the time they realize it. So the eye becomes lazy, and because the cataract is more in one eye. So the ocular side effect of a systemic steroid component is also extremely important. And especially when children just come with a systemic allergy component and you do see red eyes, I would suggest that, if the allergist friends can also ask for complaints with vision, are they happy with glasses, or is there a frequent change in glass power? These are just small parts which can be included in the history, which will help us identify and pick up ocular changes related to allergy a little earlier.
Excellent points, ma'am. Just final comments, Dr. Vinay sir, over the current discussion that we had tonight?
Well, a lot of new points, new information. As I mentioned, I mean, we used to think about something beyond I when we were driven against the wall. Okay, when we had nothing else to do. But then what is evolving now is, for us ophthalmologists, which we really have to understand is just not the eye. We have to think beyond it much early than what we used to do. So in that aspect, I think, yes, congrats to Sweta and Dr. Neeraj. You have done a wonderful job the last 3 days, I believe. Hope, this is not the end and we should, kind of collaborate and continue this work and take it forwards. And it needs a lot more, percolation down the, ophthalmology community regarding the, the need for, looking beyond the eye in these early allergies.
Right, sir, right. And final comments from our last panelist, Bhushali ma'am.
Yeah, actually, first, congratulations, Dr. Neeraj and Dr. Shweta. Here, I just wanted to, there has to be a collaboration or there has to be a coordination between the allergist and ophthalmologist. What Dr. Shweta has rightly said, the allergist also should focus on our complaints because according to World Allergy Organization also 95% of the patients of the rhinitis do have an ocular complaints, but they are not, presented or not noticed. So rhinitis patients also should ask for the ophthalmologic consultation for the to look for the just other allergic complications such as the keratoconus or steroid-induced side effects that topically, nasally and on inhale therapy they are using. And similar ways, ophthalmologists should, you know, taking what we can say is in help of allergist and immunologist at the proper time, maybe in a before tissue remodeling happen. That is very important. To our aim should be prevent patient going in a complications that is disease related complications as well as medicine related complications. It could be in steroid induced glaucoma, cataract, or Shields ulcer and keratoconus. So that's all. Thank you.
Right. Thank you, ma'am. Sir, over to you. Thank you for this eye-opening sessions for the past 3 days. Hope this symbiosis between the allergists and the ophthalmologists continue. So over to you, sir, for the vote of thanks.
Thank you, Dr. Paul, for the wonderful moderation. And first of all, I would like to thank All India Ophthalmological Society and special thanks to Dr. Shweta, who has been really, you can say, like working so hard for connecting different people at different platforms for almost past 3 weeks or so. So a great thanks to Dr. Shweta and a special thanks to All India Ophthalmological Society, President Dr. Namrata ma'am, and all others who contributed for past 3 days, and all those who have been listening as attendees. So I think Dr. Vinay has rightly mentioned and rightly pointed out that this webinar series is not the end, it is the start of a collaborative movement. And it is not only the collaboration between the allergist and the ophthalmologist, it is a collaborative movement, collaborative approach which is needed by all of us together, being it probably a primary physician or a pediatrician, ophthalmologist, pulmonologist, gastroenterologist, dermatologist, or anybody else, because it is one disease. We are actually looking at different phases of the disease, sitting in different chambers in different areas, and we are looking the disease in segregated manner. But the child is one, disease is one, patient is one, and we need to really collate together, combine together, and then exchange the ideas so that we can actually help the community, help the needy, help the indigent in a comprehensive manner. So I think we all learned together, we all have grown together, we all learned together, and we would definitely love to have more such collaborative either offline or online sessions, both in webinars, seminars, or any other opportunity given. So we would love to have that collaboration. And I am once again, on behalf of IAP Allergy and Applied Immunology chapter, would like to thank all of you for giving us the opportunity to come together on this platform and share the knowledge among ourselves. So thank you very much. Thank you.
Thank you so much, Dr. Neeraj, for this initiative.
Yeah.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Thank you, everyone.
Thank you for
Thank you,
your
sir.